from Practice Forces Studios. Thanks for listening to Improving the Business of Medicine with Kunal Jain.
Basic concept of fee-for-service versus fee-for-value is fee-for-service is incident-based, episode-based.
Right.
Patient comes to the office, you see the patient, you write the diagnosis, you take care of the issues, you put a level of intensity of care or level of care, you send the bill, it goes to the insurer or CMS, and they pay you in that, 4 weeks, 6 weeks. So that's fee for service. Then if the patient doesn't come back, it's not my responsibility. If the patient doesn't
Right.
medicine, whether the patient went for the eye exam or the colonoscopy, that is not, I just gave the instructions and it's the patient's responsibility.
Right.
Now,
Right.
fee for value is a different level where I'm responsible now. I'm holding myself accountable for making sure I brought certain outcomes to the patient while having a good engagement with the patient and brought some quality performance in my care. So suddenly the engagement becomes a constant engagement rather than just an episodic engagement, which means even when they go home, it's in my interest that they go get their eyes tested and get their blood tested and bring the cholesterol down and bring the hemoglobin A1C under control and urine test, and all that is needed for their medical condition. They bring their blood pressure under control. They do all the screening. They stop smoking, which means I have to develop a relationship with the patient. I have to have a team-based model. So I alone cannot handle care for all these patients. So I'll have a team of case managers, maybe medical assistants, maybe care coordination, people calling the patients and making sure that all these issues are being followed and taken care of, that there is continuity of care. If the patient goes to the hospital, I make sure that the care is managed properly by the hospitalists. They get all the records. When the patient gets discharged, I make sure the medications are reconciled, which is another quality metric. So suddenly now I'm no longer dealing with that transient, if I may use the word fly-by-night approach. They come and I take care of it and I'm done. I'm approaching holistically the patient's complete health. I'm educating the patient. I'm developing a relationship with the patient. And I'm hoping to improve their health, which is measurable and which is also based on their perception. And so that is the value I'm bringing. So
I completely understand this because I am into healthcare. Right. But what about people who have no idea? And as a patient, if I go and see a doctor, I have no idea whether I'm being seen. I mean, I probably know what is my insurance plan, and accordingly I would be seen. But I have no idea that from your perspective, you would be seeing me as a fee-for-service client rather than a fee-for-value client. And I was reading a recent article at MGMA, and a CFO of a very, very, highly effective organization. He said that if a CFO or a risk-bearing entity can't change the culture inside an organization to truly be primary care, they're going to fail. And he was very confident that, as you said, that it is a team approach. So how do you make sure this is the patient is educated?
We always cared. We just didn't develop the tools and the follow-ups and the processes to ensure that we got the A1C brought below 7 or the urine microalbumin was done. We didn't have the system and we didn't think like this because we were not incentivized for it. So who would spend all that money to do certain things that are so expensive? Right. And usually the physician used to do it all by himself. A conscientious physician was doing all the things we do. We were supposed to do, having a good relationship with the patient, educating the patient, making sure that they know about their condition. Okay, so now if they have diabetes, now you have to do this. You have to get your urine checked, your eyes checked, you have to take your ACE inhibitor, you have to take your cholesterol medicine. Everything we did, all the difference is, one, we are measuring it. And who's measuring it? We are ourselves measuring it because we are holding ourselves accountable. So data has become big. Data is, as they say, is the new oil, right? So data is actually, for us, it's our lifeblood. Second, now we have learned that the physician is not the, lion in the jungle kind of relationship. Whatever
yes.
Okay, so the physician
so it's more consumer-centric model.
Right. So we need support. We need to get our team helping us. When the patient comes to the front, our whole staff has to be ready to make sure that the patient has brought old records. Did you go somewhere else? Did you get the test done? Even before the patient comes in, the phone call, the scheduling an appointment. Were you in the hospital? They have to pull the records. We have to have all the consultants' notes. Now, this happened in the past. Good physicians did it. Now it's just part of the culture of the organization. Everybody is there to ensure that this is done. It's not on my shoulders alone, because I will fail if I'm the only one doing it. I won't have enough time. Someone has to follow up.
So that means, So that will basically, that means even the small medical practices, primary care practices, I know Dr. Mahajan is on the call. He can speak a little bit more. What will happen to the small practices from 1 doctor to 5 doctor primary care groups? Because they have to embrace the culture of corporate kind of, where they would have the people managing their practices, non-clinical staff. So it would open up totally a different world for them, and especially those who are small practices.
Yeah, so the first thing physicians have to do is learn about this rapidly, understand what is happening. 2, yes, there is more cost involved in providing fee-for-value care, whether it's managed care or accountable care or BIPC, or you just sent me the alternative payment model,
Medicare
first, direct contracting. They're all the same. Now the cost on the practice goes up. Now, if the leadership is smart, they will make sure that with the cost of care going up, they also get the return increase. So now the drive is to improve the quality scores. Patient engagement is better, so that when they are called by CMS to see how the physician is treating them, they give better reviews. So your CAP score goes up, your HOS goes up. So your bonuses, your payments go up.
Right.
So if you don't do that, you cannot survive. And you need better contracts. So, if you continue with the fee-for-service model and you expect to pay, to function as if you're fee-for-value, you won't be able to afford it. And that's why you are seeing a lot of physicians nowadays don't start their own practices. They're either becoming hospitalists or they're joining big groups. It is very difficult now for solo physicians to survive and thrive. So
what's the path moving forward for them? If people who still wants to continue and manage, how can those small practices manage fee for value, as you said?
They need to align with organizations that are good at it. So, for example, even for us, we have what is called an independent physicians association. So even physicians who are solo, we give them all the tools, we give them all the data, things that they wouldn't have. I mean, imagine 10 years ago, we didn't have EMRs in our practice, right? We had to push it through because there was the whole initiative from
a lot of people signed up because of the incentive thing.
That's right. So here also similar. You'll have to start doing all these things: quality care, compliant care, evidence-based medicine, documenting everything correctly, making sure your charts are audited, making sure all your codes are going to CMS, all your HCCs, all your gaps are covered. Your star ratings is 5 or at least 4.5.
Tell me a little bit about the star rating. I really want to understand this scoring system you have, because I was trying to understand this morning and I saw an article and I was very interested how I understand, like, from the billing perspective, that CPT code drives the reimbursements in fee-for-service model. But now when they are talking about that, even they are doing audits in ICD codes, and when you do the audits in the ICD codes, and you try to change the SCC code, and then it changes the score. Yes. So tell what would you, I know you're the expert on this, so tell us about it. People would like to know about it. This is something really everybody wants to listen about it.
Yeah, I can never say I'm an expert. I'm always learning. That's all I can say. I'm an expert. If I may use the word, I'm an expert in trying to learn.
So let's learn it together. Yes.
So think about it. What happened with DRG in the hospitals.
Right.
If a patient goes to the hospital, just has chest pain, CMS will pay the hospital just a certain amount, right? Say $3,000. But if the patient had a heart attack, patient had heart failure, had diabetes, had hypertension, had cirrhosis of the liver and COPD, what is called the case mix index, the diseases, the severity of the illness goes up. And because of this case mix index, the DRG, the diagnosis related grouping, becomes different. And so the hospital gets paid more because they were taking care of sicker patients. So the sicker the patient is, more you get paid for taking care of the patient. That's the basic understanding. Now,
so that the risk which they manage, why does it called risk? What is the risk-based criteria here?
I'll come to it. Let's first understand the case mix index, right? So similarly, in the office, you have what is called a RAF score, risk adjusted, or MRA, Medicare risk adjustment. So suppose someone has just hypertension. Medicare will give a certain amount, say $700 to take care of the patient, right? This is the premium. Think of it as insurance. When you have an insurance, the sicker you are, the higher your premium is, right? Same thing here, but here the premium is being paid by Medicare. So if patient has diabetes and heart failure and coronary artery disease and a stroke and COPD, now Medicare will pay more, maybe $1,000 to take care of this patient, which makes sense because sicker the patient, more money will be spent on their testing, on their treatment, on the consultants.
Once the billing is done, and then the things are gone, and then again you do the recoding, and then you send the bill again. This whole process is like very time consuming and it's a lot of administrative headache. Is it really worth to do it? I mean, it's all.
If you want to do fee for value, yes, that is the headache. And that is why if one wants to transition to fee for value, one has to understand several layers in this. This is a multi-dimensional approach. It's not a one quick, stroke of pen. Okay, we're going to become fee for value. Now, getting the diagnoses, the HCC conditions, not only to the health plan. So that means your biller, Biller has to be, first you have to document these conditions properly, compliantly, legitimately.
Which is a doctor's work, right? The physician has to.
Right.
So the first thing is doctor has to learn how to document it properly. And that's the training. Like in your organization, you said you guys provide training to your doctors.
We have a whole education department spending.
And you really handhold them. They have time. You give them. Okay.
Yeah. You have to audit the charts, make sure they're not documenting incorrectly, make sure that they're not just writing diagnoses, that there are really things they're taking care of. You just don't slap 20 diagnoses. These are legitimate diagnoses, and you're doing something about it. So someone is on insulin. If I write diabetes, that's fine. If someone just came in and my sugar was 105, I can't write diabetes just because I think like that. Now, 20 years ago, you could do that. You could write COPD. You did not need PFTs. You did not need the CAT scan for emphysema. You just wrote it because you listened to the lungs and you said, this patient has PFTs. Now you have to prove it. You have to document why is it. Otherwise, the coders, good coders or compliant coders will not even pick it up. Once you have coded it, it has to get billed. And since you are the expert in billing, you have to make sure all those HCC codes, even if they're 16, 20, more than 8, they are all transferred. They are all sent to your claims gateway. Payment gateway. Then it goes to the insurance. Insurance then takes it and sends it to CMS. So we call them the 7 steps of leakage. Every step you will have a leakage, at least 5%. So CMS will first receive it. They'll give you MO02 file. This is what we have received. Then they will give you an MA04 file. Okay, we have received it. We have accepted it. Then there is another file, MA06, I think it's called, which now not only have we accepted it, we're going to pay you for it. And CMS itself says that we will not be perfect. We're going to make mistakes. We'll have 5 to 10% error rate, which means now what, Kunalji? You will have to start watching it and you say, oh my God, if CMS is making a mistake, then who is going to watch CMS? Nobody watches CMS. But here we take the responsibility to watch it. Now, is that a risk? Of course. We are taking a risk for everybody's performance, right?
Yes.
And if we don't get paid for what all we have done, then guess what happens? we don't get the right amount of payment, and we have already incurred all the cost. The cost is incurred now. Payment is going to happen 6 months, 18 months, 12 months from now. So we are the ones under the gun. So it is risk.
What do you think is going to be the future now? When especially what's going to be the future now after this pandemic and COVID and a lot of these shared, like I'll give you why I'm asking this, because this yesterday in Tampa Bay Times, you will see a big article when our President Trump announced that insurance companies don't need to charge copay, deductible, or any kind of amount if you are screening COVID patient.
Right.
Now they have announced it. Everybody understood. Oh, let's get a corona testing done. Yeah. And this morning I was on the road finding the corona testing center because I had a cough, and my doctor said, "Go and get it checked." Now it is not that easy. When we looked as a billing company, we looked into the things. You can only get away with the cost or with the shared services agreement if you have corona positive. But if you are negative, you still have to pay the copay and deductible and everything as per your insurance.
Right.
Patients don't understand it. But this is a trick. I mean, why would somebody? And this is what's happening across the board. And that was the article. So a lot of times these things, patients don't understand it. A lot of doctors don't understand it. Why they are making it so tricky. So what do you think a future is going to hold?
So, well, COVID has created a very interesting situation where things are moving so fast. I mean, talk about adapting, right? In the old days, when we started 1990s, we were given time to adapt, 2-3 years. The government will say, okay, we're going to start ICD-10 in 3 years. And then also there'll be another 2-year delay. So we said, okay, fine. EMR will be
5 years.
Starting, right?
EMR was a 5-year plan like India.
Right. So you'll get paid. And if you start early, you get paid, $37,000 per provider. Right. Yeah. So you were given time. Now with COVID, with this epidemic, we have no time. So, the leader says this needs to happen. Now everyone else scrambles and tries to play catch up. Not only we doctors, you guys, administrators, managers, billers, who keep us safe and avoid the risk. It's also, remember, all CMS is now hustling. The operational infrastructure is hustling to make this happen.
Right.
So the intent is good, but how do you make it happen? And what will be the future with COVID? I think this is a great opportunity. That's my opinion. As Churchill said it, no crisis, no good crisis, I think he used the word, should be wasted. So we should not waste this crisis. We should turn it into an opportunity for us and put it to good use. The whole country should learn from it. What are our flaws in approaching this? How do we make it a streamlined system? We have such a bloated healthcare system with so much. Our administrative overhead in healthcare is the highest in the world. 18% of GDP is spent on healthcare. Yet we are not among the top 10 countries in the world in terms of healthcare metrics. I mean, this is shameful. We have the best technology, everything possible, the number one superpower, and we cannot take care of our patients in a safe and compliant way. So something is wrong. Our drug costs are much higher.
What is wrong at this moment? What are the top 3 things comes to your mind?
I'll tell you, in my opinion, number one is a tremendous wastage. I mean, it's unrealistic, it's unsustainable. You cannot...
During the patient care, you mean? During the patient care?
Not actually, patient care is fine. It's end of life where you waste so much money. The graph goes like this, and patient lives a week, and you spend in a week what you spent in their whole life. Money is wasted on end of life where money should be spent on preventive care, primary care, diagnosing early, making sure they're safe. Look at the drug costs. I mean, drug cost for insulin here is $350 per month. In Canada, it's $50. Tell me it's the same insulin. I mean, it's crazy. MRIs, we have 32 MRIs per 1,000 patients. I think I read it somewhere. Per 100,000 patients in US, 8 in Canada. Now you can't tell me that, we suddenly have more back pains and we have more spinal issues in our country or So I think we are overutilizing. We don't have maximized impact of money should be used to improve quality of care across the whole population. And Barwick and Nolan had done this beautiful study.
Right. I have two thoughts. No, you were absolutely right in that sense.
Yeah, so wastage of resources, there's tremendous wastage. We are not having maximum impact of our resources.
So that's fantastic. I have another question here while Dr. Mahajan writes his question. So in year 2020, I was trying to find some risk-based these contracts and initiatives which is taken by Medicare. And I found that there are two different initiatives which are taken for primary care physicians by Medicare in alternative payment model. And in this approach, they basically trying to hold providers accountable for achieving specific quality performance goals in an efficient manner.
Yeah.
So in turn, group practices participating in an APM receive added incentive payments to achieve these goals. Are you aware of? So like one of them, because you just talked about the end of life planning, is a end stage renal disease treatment choice model. Yeah. So I don't know if you've heard about it, but this model is really picking up because a lot of doctors are trying to apply for those incentives. There's another model which is called primary care first, where to participation, it's basically if patients are seriously ill, how you are going to take care of them. Basically, in my common view, if you're saying basically you are increasing their life if you're going to take. So the end of life, what you were talking about, cost is going to be more if we are going to follow this model. That's what it seems to me as a normal person.
Yes.
I would like to know your thought process on that.
So the concept is the same. Similar to accountable care, similar to managed care, similar to BIPCs, bundled payment care initiatives, a primary care first model, direct contracting model. Three things. One is quality. So you're going to be measured on quality of care. Whether it's seriously ill patients, whether it's on the BIPC patients where you have diagnoses selected for your bundle payment, say hip surgery, knee surgery, patient with heart failure, patient with sepsis. So these are diagnoses, and they're going to follow whether you followed they're going to check whether you followed the standard of care or not, quality of care, right? Which includes your HEDIS, includes your CAPS and HOS, patient satisfaction, patient education, outcomes. That's quality. Number two is utilization. So are you controlling costs or wasting the resources? For example, patient went to the skilled nursing facility. Nobody went there. Nobody saw the patient for the next 3 weeks. Patient goes back to the hospital, gets admitted again, has decubitus ulcers, muscles are weak, pneumonia, because nobody followed up and took care of the patient. So wastage of resources again. Patient's medications were changed when the patient went to the nursing home. Nobody checked on it. And now you have Coumadin and Xarelto at the same time. This patient is high risk for bleeding. And so you have increased the cost. So 40% of your readmissions are because medications are not reconciled properly, according to one study. So second is utilization. Was the utilization based on evidence-based medicine? And did you do proper case management and disease management? And third is compliance. Are you following the regulations? You're not cutting corners. You're not making up bogus diagnoses. You're getting audited. You're auditing yourself.
Governance compliance, what basically you're talking about.
Right. Governance, risk, and compliance. So these are the three things, and all these models, no matter how, whether it's seriously ill patients, whether it's accountable care, Medicare patients, whether it's managed care patients, these are beginning to overlap. You'll see. So NCQA, who's giving you the quality guidelines? It's the same organization for all these. So you think there'll be different things? If you're going to give different quality guidelines for one way and different quality guidelines for the same patient in another organization? No. So they're overlapping. There are about 35 quality metrics on our accountable care. Or even on accountable care, you have next gen, you have enhanced models, you have tier 1, tier 2, tier 3. Now, those are nuances, whether you're higher risk, lower risk, whether you're allowed to negotiate with nursing homes directly and admit.
So when you talk about this risk, again, I want to understand from a very normal person as a patient, what would patient understand when you're talking about risk-based model? I understood the financial risk you talk about.
Right.
What is the risk? Is it a patient care risk, or what is the risk which is inherited in this model? And that's why they're called risk-based models and risk-based payments.
So the old concept of risk was when we did managed care contracts in the old systems, they say the 90s, especially
capitation payment system.
Right. So the whole premium was assigned to that IPA. Now they had to do all the healthcare within that premium.
Correct. Now, budget. A budget was
right, and there was standard amount of money per patient. That's it. This is the money. $400 in Hernando County was given. Now you have to take care of all their needs. So if you have 100,000 patients, Humana is going to take care of those patients within that amount of funding. Now, if they spend more than that, then Humana is responsible. If they spend less than that, then Humana gets to keep it. So this was the risk model. They are taking the risk of care. That is why they developed all
but the care cannot be compromised.
Right. Right. That's why the withholding of care became so important. So as over the years, as it evolved, then you started having HCC and the compliance and auditing. That's why you have moved to an accountable care system where now you're holding yourself accountable that whatever diseases are being documented are documented correctly. Treatments are being done right. Everything. So the protections for patients were created. Tremendous protections. Patients have a right to appeal if they feel something is being denied incorrectly. Now it goes both ways. Some patients want the Brooklyn Bridge, and you can't. It's CMS won't give you the Brooklyn Bridge. But where sometimes there's a legitimate request that they need certain thing, and provider may not agree. Patients have the right to appeal. Actually, usually it's not the provider who denies. The insurance company denies it. All we do is, suppose there's a request, we send it to the health plan with all the records. The health plan will decide whether it meets the criteria, what we call LCDs and NCDs, locally covered determination. So in this area, in Spring Hill, in Hernando County, is this kind of surgery allowed for this condition. Now, there is nationally covered determination. So across the whole country, if you have this condition, this issue is, this kind of procedure is allowed. Now, then there are gray areas where experimental things are being done, things that are not approved. Like now patients want this injection of stem cells. It's not approved yet, right? Patient requests it, health plan will deny it, patient has a right to appeal. It goes to CMS. There are 5 layers of protection for the patient. And they also say, no, it's not covered. The patient has to pay it cash. Medicare will not cover it. So it is a balance that it has all has to be documented. You can't just make up things. If there's a request legitimately and you have a timeline, I cannot.
I understand. You have acquired all of this wisdom over a period of time. And sharing that wisdom with the other doctors and growing the group, it's a lot of burden, It
is. And why do they call it risk?
Now I can understand it. So Dr. Mahajan, let me introduce you. Dr. Mahajan is on the line, and he's I know him personally for over 15 years. He's a wonderful primary care physician, and he has an amazing practice in Largo area. And he has some question for you. And he said, thank you very much for your great insight for fee for value model. And he also said he wanted to know, what do you think about role of remote telehealth devices like BP and weight scales in FFV model, which is fee for value model? And again, these devices would probably, come because of the, now the progression of telemedicine and telehealth. So what do you, which is a very good question. What do you think about it?
I think it's a tremendous shift in healthcare. And I think it is very advantageous, and wisely CMS has allowed us to use telemedicine for patient visits to document the conditions. And I think it's something that will enhance us. Almost, I was reading an article today, 40% increase in our ability to see more patients. Now, the challenge is, of course, our patients are not ready to do telemedicine. 30% of my patients have the required applications and cameras or whatever equipment they need to be on telemedicine. But as it evolves, and as what is called the Internet of Things, you give them little devices to keep with them, to keep at their homes, almost like your, what is that, Alexa on steroids, if I may use.
That is true. I heard Alexa is managing even patients in nursing homes.
Right. So weighing machines, right? They will all be connected to you. Your blood sugar check, you check it automatically.
My weighing machine at my home is already connected with the. Yeah, they are coming up with a lot of these things. That's true.
Right. So if you went to HIMSS, they had this stethoscope on your iPhone. You just you put it on your chest, and the reading go to the doctor right away. We're already checking pacemakers, and through the jack phone jacks you connected, and the doctors are getting it. So I think with this Internet of Things, telemedicine, and devices that are coming tremendously with the data management, right? So our technology has advanced significantly. Of course, your 5G has come, so you can handle a lot of data coming in, and analytics have improved, your augmented reality, your robotic process automation. All these have taken us to a new level, natural language processing. So all this increases the speed of taking care of the patient. It's almost like patient is living in my home. I have everything. Yes. I'm checking daily what their weight is, how their lungs sound, how the rhythm is.
Do you think it's an opportunity for entrepreneurs to come up with more models and more things like that, and do some more inventions in those areas?
So Americans being creative by nature and are playing. This is healthcare is the biggest opportunity for entrepreneurs trying new models, trying new devices.
Yes.
Yeah, I mean, people. I went last year at HIMSS. They had a bed. You sleep on the bed, and that bed is taking all your readings, your oxygen levels, whether you're snoring or not. Your sleep apnea testing is happening. Whether when you're getting up, how much is your blood? I mean, all kinds of fancy things are being done. Now I heard of a device that will monitor your rhythm while you're asleep to see if you're higher risk for heart attack. Right. So I think a lot of this is where technology, while being disruptive, can truly make things interoperable and truly reduce the wastage. We talked about the number one problem with our healthcare system, that tremendous wastage. If we use technology properly, everything is in silos. If we can connect it and make it interoperable, and that's the second problem, we're not using technology. Healthcare has lagged behind technology. Everywhere else, technology is ahead in almost every field. But as Bill Gates said, in two fields, it has not caught up, which is one is healthcare, and second is entertainment. So now it's time to catch up and move up on the scale. So, I think Dr. Mahajan's point is well taken. This is definitely a great opportunity.
Fantastic. So I think we had a great session today. It was, right on the last minute, and we spoke about Dr. Singh. He also asked about, he has another question. What do you think post-COVID era ACOs will survive? Again, coming back to the same thing. What's the future going to be for them?
I think they will survive. That's just my impression. Looking into, the tea leaves, just making predictions. But I think they will survive because they deal with something fundamental that we need in our healthcare system, which, as we discussed, fee for value. Whether you call it ACO, whether you call it something else by the same name, quality is in. You're going to measure quality. Patient satisfaction, patient engagement is in. Regulatory oversight, compliance is in. They're not going anywhere. So I think ACOs are in. They're going to stay. They might have to adapt a little bit. And I think CMS is trying to help with how the ACOs are paid up. And the third thing I wanted to say, which I haven't, I just wanted to close it. Remember the three things that our healthcare system needs? Although I have many more, but third thing is get politics out of healthcare. We have leaders who have goodwill.
There was some problem in the speaker. So come again.
Get politics out of healthcare.
politics out of healthcare. So what do you mean by that?
It should be a bipartisan approach. It should not be a time to score points. Anytime someone comes with an idea, you shoot it down and try to create a fear frenzy. And then you, like drug companies, you try to reduce costs, and then they go on with $1 million ads that, this politician is trying to affect your coverage.
Do you know how many people bought this stock in last 2 days for mRNA?
No, I don't.
This is the company which is approved. There are only 2 companies which is approved for this, for the corona testing, and mRNA is one of the stock symbol, Medic something, and Gilead is the another one. They both, and there's the mRNA stock is 50 at this moment, but a lot of people are buying it, especially the physicians, because they know that there is a strong possibility of a better outcome or a positive outcome of this drug, especially in this time, because as you said, politics, we don't know who are their friends and who are their foes. If their friends might be supporting them at this moment, then they may come up with something.
Yeah, politicians and lobbyists should stay out. Let people in a bipartisan manner resolve this healthcare crisis, which is worse than the COVID crisis, by the way.
Right.
We have 60,000 deaths from this, but from our own mistakes, we have about 200,000 deaths every year because some drug was not given on time and there was an overlap of medications and poor continuity of care. So that is, as serious, if not more serious crisis. We just don't notice it, but it's there and we need to fix it.
Fantastic. Dr. Mahajan, I'm sorry you could not come on the video, but we took 2 questions from you. If you have any more, you can write, but we are going to end this session now in next few minutes. Dr. Singh, any closing remarks? What's going on around you, around here? Any final, any new information for patients you want to share?
Well, the only thing I'll say is keep learning. Let's keep creating a platform where we keep sharing ideas, how to do things better, and keep advancing our value in what is called the chain, right? We keep going up the ladder as we learn more. Every day we are learning something new. Let's keep sharing that with each other, and I think I appreciate you opening up this platform for everyone else.
No, absolutely. Thank you so much, and I really appreciate everybody who were here. We are going to have another session very soon. Thank you.